Good morning, everyone, and welcome to Internal Medicine Grand Rounds. I'm Dr. Tim Williams, Chair of Medicine here, and it is my pleasure this morning to introduce the introducer. Our speaker is actually going to be Yash Kothari. He's an assistant professor here in pulmonary critical care medicine. He'll be talking about evolving treatment of pulmonary hypertension, but the real introduction is going to be done by our wonderful leader in the Division of Pulmonary, Dr. Mohammed Saad. Dr. Saad, take it away.
Thank you, Dr. Williams. Good morning, everyone. It's my pleasure to introduce Dr. Kothari. Dr. Kothari did his undergrads at University of California, Irvine, followed by medical school at St. George's University. And we were fortunate to get him here as a resident in internal medicine in 2014 and served as a chief resident for 1 year before moving on for his fellowship. He completed his fellowship at University of Southern California, where his family resides. And again, we were fortunate for the second time to bring him back to Louisville and joined our faculty in 2021 at the height of the COVID. The true strength of Dr. Kothari, of course, is his academic interest is pulmonary hypertension. And during his residency here, he worked with our pulmonary hypertension team, Dr. Al-Kirsch. He had numerous publications and developed his career and interest in this field. And as I said, we were fortunate to bring him back. He's been leading our pulmonary hypertension team with Dr. Shelley, and he did extremely well, growing our division and make it more a multidisciplinary program for the pulmonary hypertension. And today he's going to be giving us the updates on the treatment of pulmonary hypertension, because there are a lot of new changes there. So thank you, Dr. Kothari, and go ahead.
All right. Thank you, Dr. Saad, Dr. Williams. All right. Good morning. We're going to go a little bit brief overview of the diagnosis classification of pulmonary hypertension, as well as the updates and treatments. So, objectives, we're going to talk a little bit about just base overview of pulmonary hypertension, what to look for, how we make the diagnosis, the risk stratification, as well as treatments. All right, so the prevalence of pulmonary arterial hypertension in patient demographics. It is, in my opinion, extremely underdiagnosed. However, per reports, there's variable range of 10 to 52 million cases. Most of them are idiopathic, which means we don't really know why they're being caused. The majority tend to be females, and the mean age of diagnosis used to be in the mid-30s. Now it's all the way up into the mid-60s. All right, so prevalence of pulmonary hypertension. Probably about 1% of the global population. As you can see, the most common reason of right heart failure is left heart failure. And, lung disease makes up a pretty large portion of the pulmonary hypertension patients. The actual data for true pulmonary arterial hypertension is based on it's kind of a rare population that we deal with, but this is in general the trend of the diagnosis of the disease. All right, clinical presentation. Vast majority of patients just report dyspnea on exertion, kind of chronic fatigue. It's very kind of nebulous symptoms for the most part. And, a higher degree of suspicion is needed to kind of really isolate the diagnosis. Clinical symptoms. So usually you would start with, dyspnea on exertion, and with progressive changes, you can get all the way up to PA dilation symptoms, which are kind of more of the hoarseness and exertional chest pain. They tend to be a little more late stage. And you can have signs of RV backward failure with JVD, abdominal distension, hepatomegaly, ascites, edema, as well as the classic pulmonary symptoms that we think of with like cyanosis and prolonged capillary refill. All right, so WHO classifications. Group 1, which is the vast majority of what the stock and all the data is based on, which is true pulmonary arterial hypertension. Group 2 is pulmonary hypertension due to left heart disease, which is by far the most common cause of pulmonary hypertension. Group 3 is pulmonary hypertension due to lung diseases and or chronic hypoxia. Group 4 is chronic thromboembolic pulmonary hypertension. And group 5 is unknown or multifactorial mechanisms. We'll go a little bit more into detail about all these different groups. All right, so group 1, vast majority are idiopathic, as we talked about. There's a fair number that are inherited, drug and toxin induced, connective tissue disease, persistent pulmonary hypertension of the newborn. We don't really see that much. That's more a pediatric issue. HIV, portal hypertension, congenital heart disease, schistosomiasis. We don't really see that as much in the United States. Due to left heart disease, LV, diastolic and systolic dysfunction, valvular disease. Group 3, COPD, interstitial lung disease, sleep apnea, chronic high altitude, and developmental lung disease. Then group 4, CTEPH, we talked about, pulmonary obstructions. This includes pulmonary tumor angiopathy as well as chronic PEs. And then group 5 is kind of like a mixed bag catch-all, which includes sickle cell, sarcoidosis, chronic renal failure with the AV fistula, hematological disorders. All right, so group 1. Like we said, the vast majority are idiopathic. There are some genetic mutations. Drug and toxin induced, this seems to be the bulk of what we get referrals for, especially patients that have had, exposure to methamphetamines. Toxic rapeseed oil is, there was an incident back in Spain where there was like adulterated rapeseed oil spill and the cleanup crew exposure had a bunch of people diagnosed with it. That's when they found the association. There are various, chemotherapeutic agents in here. Cocaine, Hep C, sofosbuvir. There's a lot of stuff that is possibly associated as well as definite associations. Back in the 90s, aminorex based weight loss medications were very common, and there were a lot of people taking those, and those have also been implicated with pulmonary hypertension. Okay, so a little bit about genetics. So there's a whole bunch of different mutations that commonly BMPR2 is really the one relatively common one that is tested for, but there's a lot of basic science stuff involved in here. Like we said, the vast majority of the genes are still unknown. There are a few that are established, however, it doesn't really change how we approach these patients. All right, so the vascular remodeling, this is kind of like a shared feature amongst all the different causes of pulmonary hypertension. In general, you would have some sort of risk factors and associated conditions with it that would cause vascular injury, which at this stage is when we'd like to try and capture them when they're still in a reversible state. Eventually, you develop these advanced plexiform lesions within the pulmonary vasculature, which tend to be an irreversible cause. This is a little more histological view of it. And due to, pulmonary vascular damage, you have changes to the media and the muscular fabric of the pulmonary arteries, which eventually causes luminal narrowing and plexiform lesion formation. All right, so what happens with pulmonary hypertension? You get an increased RV afterload, causing RV hypertrophy, reduced RV perfusion, RV ischemia, alteration in some gene expressions that causes metabolic rewiring, impaired angiogenesis, and reduced RV function. So this is kind of like the RV failure loop that pulmonary hypertension patients end up in, and this is what we're trying to prevent. All right, so diagnosis, how do we diagnose it? So usually the first screening test is an echocardiogram, and this is something that is interesting because there's a lot of places that do echocardiograms without a focus on the right side, where they're just looking at the ejection fraction, the mitral valve, and no real data is given on the right side. We are lucky here that our echocardiogram interpretations are excellent, and Dr. Stoddard reads the vast majority of the echoes for my patients. And so we usually, if we give them an indication of pulmonary hypertension, we get a lot of the right side hemodynamics. The key is looking at the tricuspid regurg velocity. So if the tricuspid regurg velocity is less than 2.8 meters per second or 280 centimeters per second, it is less likely to be pulmonary hypertension. All the way into you get pH likely, where you have a high tricuspid regurg velocity, elevated pH systolic pressures, and the signs of echocardiographic variables of pulmonary hypertension. You see a RV, LV, basal diameter. You see flattening of the interventricular septum, RV outflow Doppler acceleration. You can see pulmonary regurg velocities, IVC diameter, as well as right atrial systolic area. All right, so say you have a patient that fits, pH possible or pH likely. This is the diagnostic workup that most of the patients that get referred to my clinic go through. So we'll have an echocardiogram at baseline. We have a pulmonary function test, and then echocardiogram, we're looking for LV function and kind of looking at group 2 pulmonary hypertension rule outs. CT scans are done for most patients to look out for interstitial lung disease, parenchymal disease. Sleep study for sleep apnea. PFTs, obviously to rule out obstructive or restrictive disease. The common sign for pulmonary hypertension in group 1 patients is normal spirometry, normal lung volumes with a very, very low DLCO. If we have concerns for CTEPH, we get a VQ scan, and then serologies for connective tissue, HIV, the rest. However, the right heart cath remains the gold standard for diagnosis. So all of this kind of helps you classify into what group the patients would fall into, 1 through 5. But the right heart cath is the clear gold standard. All right, so this is what we do during a right heart cath. We need a mean PA greater than 20. Used to be 25, but back in, I think, 2016 or 18, one of the years is when they found that they were missing a vast majority of pulmonary hypertension patients that were falling in the mean between 20 and 25. So the threshold was lowered to 20. And then this is the true group 1, which is the mean over 20 with a wedge less than 15 and a PVR greater than 3 Woods units. Post-capillary pulmonary hypertension patients, this is more of the group 2 that we see, where you have a wedge greater than 15. And those are usually isolated post-capillary, where they have a PVR less than 3, versus over time, and this is kind of like a split model. Over time, the post-capillary component causes vascular changes in the pre-capillary, fall into pulmonary 3 and post-capillary pulmonary hypertension. The interesting thing was that this is the US criteria for it. However, the European criteria was changed. As you can see, the big change was they dropped the PVR threshold down to 2 Woods units. And this was in 2022. So, right. So vasoreactivity testing. This is something that is done at the initial right heart cath it's recommended for most group 1 patients. The definition of vasoreactivity is you need a reduction in your mean PA by more than 10 to under 40 with an unchanged or improved cardiac output. It is recommended to do vasoreactivity testing with inhaled nitric oxide or IV ibuprofen. A lot of times it's done with adenosine. All right, so we have a diagnosis of pulmonary hypertension. Where do we go from next? The important thing is to risk stratify these patients. So this is a table of risk factors that were associated with patients being high risk, greater than 10% risk of 1-year mortality versus low risk, less than 5%. So obviously, if they have clinical signs of right heart failure, they tend to be high risk. Progressive symptoms, rapid onset, rapid progression, high risk. Repeated syncope, high risk. Functional class 4, high risk. 6-minute walk distance, less than 165 meters, high risk. Cardiopulmonary exercise testing, NT-proBNP, echo, and obviously hemodynamics. So this is a lot to kind of memorize and remember. So we have some simplified scores now. So the first thing is to identify their WHO functional classification, which obviously if they have symptoms with any physical activity or symptoms at rest, they tend to be class 4 versus no limitations of physical activity, class 1. All right, so various scores have been developed to assess the risk of mortality in patients with pulmonary hypertension. Most of these are based on registry analysis. The common ones that you will see are the 2022 ERS ESC risk calculator. There's a non-invasive French criteria, and there's a Compara for strata risk assessment. You can use either one of them. All the data for all of them tends to correlate. We in the United States tend to use the REVEAL score. And in our clinic on the initial visit, we do a REVEAL light. And once we have the right heart cath, we do a full REVEAL calculation. The reason is we need a PVR and a mean right atrial pressure for the full REVEAL score. And okay, so what is the point of the risk stratification? The treatment goal for all pulmonary hypertension patients is to try to bring them into a low risk status. So patients that are intermediate or high risk, the goal is to treat them to bring them into low risk and to improve their 6-minute walk distance to greater than 440 meters. That tends to correlate with improved RV function and normalization of cardiac biomarkers. This risk score reassessment needs to be done every 3 to 6 months. We usually do it at every visit or every annual visit. Okay. So bulk of the talk we're going to spend on is on the treatment. So there's going to be a lot of new medication names that people may be unfamiliar with. All right. So these are all the medications that are FDA approved for WHO Group 1. True PAH. There's one medication that's missing in here that was recently approved back last year, which we'll talk about a little bit. All right, so calcium channel blockers. These are only for patients that have demonstrated vasoreactivity during the right heart cath. And, it's the common ones that we use for blood pressure control: amlodipine, nifedipine, diltiazem. Verapamil should be avoided due to negative inotropic effects. All right. Easily accessible, low cost, minimal side effects. The problem with vasoreactivity testing is that in general, less than 10% of pulmonary hypertension patients tend to be vasoreactive, and only about 10% of that 10% will actually have a sustained long-term response to it. So unfortunately, while it would be nice to have a relatively benign medication to kind of treat them, there doesn't seem to be great long-term data. So this is the picture that we shared earlier. It's the shared features of vascular remodeling in PH. All right, so supportive therapy. Diuretic therapy in patients with signs of RV failure and fluid retention. This is a relatively controversial thing, but seems to be most beneficial. Continuous long-term oxygen. Oral anticoagulation used to be a very well-supported supported treatment. However, we're tending to back away from those outside of Group 4. Okay. All right. So this is kind of like a timeline of when medications were approved. So we had one drug in 95, and then in the 2000s is where we've had a lot more approvals coming through. And as we go through, all the way up until 2015. And so this is the pathway that we use for treating pulmonary hypertension. Okay. So the nitric oxide pathway, you have dysfunctional endothelium in PH that causes low nitric oxide levels. Nitric oxide is a potent vasodilator. It stimulates cyclic soluble guanyl cyclase to convert GTP to cyclic GMP, which is broken down by phosphodiesterase 5 into GMP. The cyclic GMP is the active component to it. So PDE5 inhibitors, sildenafil and tadalafil, inhibit phosphodiesterase 5, increase cyclic GMP levels, and promote vasodilation. Riociguat is a soluble guanyl cyclase stimulator. So that is the nitric oxide pathway. The endothelin pathway, you have endothelin receptor A and B, and we have specific inhibitors to the receptors. Prostacyclin pathway, obviously, we have a prostacyclin receptor within the endothelium, so that causes vasodilation, and stimulating that receptor is one of the ways to do it. Right, so talking about the endothelin receptor pathway, we have ambrisentan, which blocks endothelin type A, bosentan blocks A and B, and macitentan blocks A and B as well. So obviously, bosentan and macitentan tend to be a little more potent pulmonary vasodilators. There is decent data for all three medications. Phosphodiesterase 5 inhibitors, commonly used for erectile dysfunction, were found to have benefit in pulmonary hypertension patients. All right, Riociguat. This is a medication that it's relatively new, but it's used for pulmonary hypertension as well as chronic thromboembolic pulmonary hypertension. It improves 6-minute walk distance, improves functional class, and however, this cannot be combined with the other nitric oxide pathways because it causes potent hypotension. Right. The prostacyclin analogs. This is so these medications come as continuous IV form, sub-Q pump, inhaled as well as oral now. And the challenge with these medications is they all need to be started at a low dose and titrated up slowly. The big issue is that any interruption in treatment causes a rebound pulmonary hypertension with it. And so we need to avoid interruption at all costs. And if there is interruption, then we have to kind of restart low and titrate up again. Most of the side effects of these medications happen during the titration phase. And this is the prostacyclin receptor agonist. This is an example of the parenteral pump. So we have this CAD legacy pump is used for continuous IV infusion. We have a few patients that are in the hospital that have this, as well as patients at home with PICC lines. And then this is the old CAD MS3 pump. This is no longer manufactured now. So pharmaceutical company has made the Remedy sub-Q pump. All right, so do we do one medication, 2, 3? So we're going to talk a little bit more about that. Monotherapy, they had various trials back in the day for WHO functional class 2 and 3 patients. Most of these were conditional recommendations for functional class 4. And as we see, epoprostenol was the only one that had a class 1A recommendation for functional class 4. All right, so then we go into the era of dual therapy. So this was an ambition trial, was published in 2015, and that looked at a combination of an ERA and a PDE5 inhibitor versus monotherapy. And they found that the combination therapy had reduced time to first event of clinical failure. And so initial combination therapy became kind of the go-to. These are some of the trials. So ambrisentan, tadalafil was the ambition trial that I just mentioned. And then they looked at other ERAs and PDE5s. They looked at combination with orals and IV. But in general, oral combination therapy was it's considered first-line treatment. This is a relatively newer trial that looked at a combination of macitentan and tadalafil versus monotherapy only. And they found a reduction in PVR in the combination group. At the point that this trial actually got a combo pill, so it's a single pill with both medications, got FDA approval as of last year. Okay, so then we get to the guidelines. So this was the most recent guideline published up until last year. And they recommended, as we go through this algorithm, PAH patients, confirmed diagnosis, patients with cardiopulmonary comorbidities, all risk factors, initial monotherapy, and regular follow-up. Patients without cardiopulmonary comorbidities, if they're lower intermediate risk, you do a single agent. If they're high risk, you do a dual therapy. Follow-up risk, and if they remain low risk, continue initial therapy. If they are still high or intermediate high risk, you add a third agent. Okay, so then these two articles came out back in 2023, 2024, more to 2023. And they looked at something called sotatercept, which, if we look at this pathway, you have a pro-proliferative pathway regarding Kremlin-1 and Noggin, and those inhibit the anti-proliferative pathway as well. And so they came up with sotatercept, which basically reduces this pro-proliferative pathway, inhibits the inhibition of the anti-proliferative pathway, and basically causes remodeling. So this was the STELLAR study. So that's the first one right here on the left. And in patients who were receiving PH therapy on stable background therapy, sotatercept resulted in an improvement in exercise capacity, as well as, by a 6-minute walk test. And delayed the progression of death or clinical worsening. The PULSAR study looked more at the hemodynamics of the same group, and sotatercept resulted in a reduction in pulmonary vascular resistance in patients receiving background therapy for PAH. Sotatercept is given every 3 weeks subcutaneously, requires CBC monitoring for the first 5 doses. They've noticed that patients on average have an increase in hemoglobin of 2 to 3 points during the initial titration phase, as well as they can have some thrombocytopenia. And this was FDA approved as of April of last year. So we're only about a year into this medication. Okay, so luckily after this medication was FDA approved, there was a World Symposium in Barcelona, World Symposium of Pulmonary Hypertension in Barcelona. And based on that, we have a new guideline-ish. So this integrates the sotatercept pathway into the initial 3 medication pathways that we had beginning there. All right, so current guidelines now. This is kind of the algorithm we use in our clinic nowadays, where most of our patients tend to fall in the intermediate or high risk group. So we do a ERAPD 5 at baseline. At follow-up, if they continue to remain there, then we either add sotatercept or talk about doing a parenteral prostacyclin. I have a hard time convincing our clinic patients to go on 3 therapies, including a subcutaneous pump at the first visit. That's just part of the challenge. So we kind of tend to save initial triple therapy for patients that get admitted to the hospital with RV failure. And then usually close follow-up every 3 months. All right, the other groups of pulmonary hypertension. So group 2, we were always taught that you treat the underlying disease. So if they have heart failure, reduced EF, it's more GDMT for heart failure patients. However, now based on the 2024 World Symposium, they found that, structural heart disease, symptomatic heart disease, heart failure stage B and C tend to be more precapillary dominant, and GDMT were applicable. Maintenance of sinus rhythm, ambulatory hemodynamic monitoring. And once they are in the right heart predominant heart failure group, then you have the PA-RB uncoupling. And at that point, we can consider true pulmonary hypertension treatment for these patients. Prior to this, it's hard to, treat patients. All right, so for group 2 PH, these were some of the studies that were done. They looked at macitentan, tadalafil, riociguat. These are the PH drugs, and they found, primary outcomes, small increases in cardiac output, and a lot of the studies were kind of terminated early due to high failure rates. So with macitentan, there was a high failure rate due to fluid retention. Tadalafil was terminated early. In general, there is not a lot of great data for group 2 PH patients. Group 3 PH patients have a little more data. Obviously, we treat the underlying disease, so we got a lot of referrals, especially from the VA, for COPD patients that have echo evidence of pulmonary hypertension. We tell them, we're like, you need to stay on the COPD treatment. And there is small data that we can do for COPD. So for COPD, sildenafil, tadalafil, no adverse effect on oxygenation, and reduction in PVR, improvement in quality of life and mood scores. ILD, IPF, actually there is decent data for that. So the World Symposium, again, classified interstitial lung disease as having features that were favoring no pH treatment versus favoring pH treatment. And they said that the patients that have more vasculopathic form of ILD would favor pulmonary hypertension treatment. So these patients tend to be more of the PVR greater than 4, mean pressures greater than 25, and tend to be more of the mild to moderate restrictive ventricular defect. They tend to have an elevated BNP and non-severe fibrotic interstitial lung disease on CT. So they looked at inhaled treprostinil in these patients, which is an inhaled prostacyclin. And they found improved exercise capacity from baseline compared to placebo. Interestingly, in this study, they actually found an improvement in the FVC of the patients that had IPF specifically. So this medication currently is being studied in IPF only, non-PH IPF. And we're actually a center for that drug trial. Okay, group 4. So lifelong anticoagulation for patients that have had PEs resulting in pulmonary hypertension. Refer to surgeon to assess operability. So this is actually one form of pulmonary hypertension that is positive, that is possibly curative. And the nearest center for us that does the PTE surgery is Cleveland Clinic. UC San Diego is the pioneering center for this study. However, there are other places all over the country now that do it. Okay, and this is where riociguat comes in. So when they looked at riociguat compared to placebo, they found significant improvement in 6-minute walk distance, reduction in PVR, mean PA pressures, NT-proBNP, improvement in cardiac output, and functional class. Okay, so this becomes a little more of a, so if you have, on the VQ scan, if you have occlusions in the main PA, in expert centers, PEA can be used. However, what happens in centers, if you're thrombotic occlusions are more in the lobar segmental or subsegmental arteries. There's something called a balloon pulmonary angioplasty, which is being done at more and more places where they can kind of dilate those vasculature. However, BPA requires repeated sessions, so it's not like a one and done situation. And obviously, in all of these patients, there is the risk of having distal clots, in which case medical therapy is really the only thing we can do for them. So the decision to operate is based on how accessible the thrombi would be, if there is, how impaired the patients are, comorbidities, and the patient motivation and willingness. Okay, so we have prescribed the therapy for the patients. What do we do now? This is the bulk of what my clinic does, is kind of work with insurance for coverage of the medications. And if the medications are denied, then we have a whole peer-to-peer appeal process. And there are foundations that have prescription support for the drugs. And so we work with those a lot. There's a lot of grants. There's a lot of industry support for pulmonary hypertension medications. REMS requirement. So this is something that's interesting. So it is a requirement from the federal government to reduce the risk of embryo-fetal toxicity as well as hepatotoxicity. So as part of REMS, the physician, the hospital, and the patients all have to be enrolled in this program. And it requires monthly pregnancy tests as well as monitoring LFTs depending on the medication we use. So the REMS requirement is females of reproductive potential for all the ERAs, as well as Riociguat, need a monthly pregnancy test. For bosentan, require monthly LFT and effective contraception. However, as of last week, the ERAs are taken out of the REMS requirement, which is a new thing. I just found out about it as of last week. I don't know. So they apparently found, because I think there is an ERA that was approved for IgA nephropathy that does not have a REMS requirement, so they kind of retroactively applied it to all of them. My bigger concern is we were relying on REMS to make sure pulmonary hypertension patients did not get pregnant. Now, if they no longer have a REMS requirement, we're going to have to be more vigilant about this, because pregnancy in this population is extremely dangerous. Yeah. All right. So in conclusion, pulmonary hypertension is a multifaceted disease, evolving treatment options, early recognition, referral, and evaluation and treatment can have profound effect. Me and Dr. Shirley are working on expanding our pulmonary hypertension presence here. And we're an all-inclusive center. We do our own right heart caths. We perform our own razor activity testing. So any suspicion, refer early, we can evaluate. And if there's nothing going on, we're happy to send the patients back. But yeah. Any questions? I'm sure we kind of went through it quickly, but
No, it's a lot of information, and it's good to have the update and good to see that constantly reevaluating and changing guidelines in the middle of the guideline. That's kind of nice. Does our group work with the VA?
We do. So our current system is the VA pulmonologist will get an echo, and then they'll be referred over to our clinic here at UofL.
I see. Okay. So you're seeing the patient. So the question I had is the particular VA type of pulmonary toxicity from the burn pits. Everybody saw it on Grey's Anatomy.
Yeah.
The question was, other than letting people, trying to get them in for pulmonary transplant. So is there any of these therapies? There's so many of them, and the mechanisms are so well worked out.
Yeah.
Any of them, being tried to try to help these folks?
So I don't know if anything specifically has been studied in like burn pit exposure. Obviously, if the burn pit exposure leads to more of a COPD predominant phenotype, then that's a different treatment versus if it's a more fibrotic treatment, more fibrotic phenotype, then that would our VA doesn't, I mean, I've had a few patients that were, Agent Orange and burn pit exposure.
Mm-hmm.
The challenge is our VA doesn't always approve pulmonary hypertension medications because a lot of the guidelines aren't clear cut. Like,
Sure.
as we looked at, there's no strong evidence for group 3 treatment aside from treprostinil. So when we try to do oral therapy on these patients, sometimes we get like a rejection from the VA. So then we have to kind of back work into it and have the VA people prescribe it.
Any questions online?
Nothing at the moment.
Well, that's a second one.
I have a question actually. Yash, can you, I don't know, maybe some of the audience may be interested. Can you maybe give us an idea about some of the trials that we have for ILD PH together? I think we have some of them in the division, and
Yeah.
you want to maybe.
Really, this was the big one so this initially got approval for inhaled treprostinil as a nebulizer, which is used 4 times a day, and it's like a big nebulizer that like patients have to carry like a backpack and a power supply with it.
Yeah.
And so our division was part of the trial that looked at a dry powder inhaler version of treprostinil, which is the size of like a coach's whistle. It's a much smaller inhaler. And same dosing 4 times a day. However, we were part of the site that got the dry powder inhaler approved. Yeah, and so we seem to have had good data with that. Obviously, we're a site now for the treprostinil for non-pulmonary hypertension IPF patients, because the subset of IPF patients with PH had an improvement in their forced vital capacity in this trial. So now they're looking at it as a non-pulmonary hypertension, just an antifibrotic.
There are a couple of online questions. One was actually one's scrolled up. Is there any work being done on prevention and screening for PH as in CAD?
Not so. I mean, there are certain risk factors. So I think the rheumatology guidelines recommend scleroderma patients get an annual echo. So it's more based on risk factors. Like if you have a pre-existing risk factor that's gonna predispose you to developing pulmonary hypertension, then the specific guidelines apply to that. I know our bone marrow doctors do annual echoes for certain chemotherapy agents that they use, because some of them have been shown to develop pulmonary hypertension. A lot of it depends on primary care kind of having their antennas up for symptoms. And I've gotten a fair number of referrals from our AIM clinic. But yeah.
Can I go ahead and do my question? Because
Yes.
it is about primary care and how we should handle this. Because I'm sitting here listening to your talk thinking there are probably many more patients who we could refer from primary care, and just sort of trying to sort out like where to set the barometer.
Sure.
And so do you have any additional advice? Like when you see patients, are there scenarios that come up commonly where you're like, this person should have seen me earlier? Like, do you have any advice for those of us who are seeing all the underlying causes, which may eventually lead to pulmonary hypertension? But if it is, it's probably mild and they're probably not going to become high risk. And how do we, use resources wisely?
So I think one of the things that we've seen with primary care especially is there is a fine line between too early referral versus too late referral. And it's kind of hard to adjudicate where that classification is. I would say if there is a concern or doubt, go ahead and send them to us. All we ask is you get an echo before you send them, because usually, the echo, this tends to be the most sensitive part, which is the tricuspid regurg velocity, which is not something, I don't know, like when I was in medicine clinic, I don't think I ever looked at the
I took a
tricuspid.
picture of that slide.
So
Yeah.
that seems to be the most kind of sensitive aspect of that. So I feel like if you see tricuspid regurg velocity that is higher, or you have in general unexplained dyspnea, or you've gotten a spirometry but we don't have a DLCO,
Mhm,
I would send them for a formal PFT.
mhm.
And if the DLCO is lower and we don't have an explanation for it, those are people that should be.
Okay.
We have like three more questions from online. First one is from Dr. Frank Parker. He wants to know, what are the indications for referral to your pulmonary hypertension study?
Yeah, so I mean, like we just talked about, any sort of RV impairment on echo, increase in tricuspid regurg velocity, unexplained dyspnea, or a low DLCO on PFTs that is not explained by, or even if there is an explanation for it, I would think about referring those people.
Next question is from Lori Earnshaw. I don't know if you know like Earnshaw. She says, at the end of life, those of us practicing hospice and palliative care often find that discontinuing these medications is a barrier to enrollment in hospice. At what point do you see the burdens or lack of benefit of these medications indicate that it is reasonable to discontinue?
That's a tough one.
Yeah. So I think, these medications, I agree, are extremely expensive. So if a patient is enrolling in hospice, either due to pulmonary hypertension or heart failure or any other comorbidity, I think it's probably reasonable, because all of these medications, they're shown to improve quality of life, functional classification. We're talking at least 6 months, if not longer, for treatment. So I think if your patient's overall prognosis is probably less than 6 months, I think it's reasonable to start backing off on these medications.
And then one, go ahead.
We have an expert in the room, former division chief.
Yes.
How would you, because obviously the symptoms are going to get worse and the mortality is going to hasten if we stop those drugs. So how do you balance?
Well, I think it's a lot of shared decision-making and goal setting with patients. I'll follow that up with a question. I think what I'm sitting here thinking is, can there be a role potentially for using some of the more affordable medications for palliative purposes for treating the symptoms? So for example, maybe they've been on, a continuous pump, but, would it make sense to try to transition to sildenafil, which you can get for $20 a month with a good effects coupon?
So usually the people that are severe enough would probably already be on sildenafil.
Okay,
At least if they come through, our
Yeah.
clinic and stuff. So I think it's reasonable to stop the expensive stuff and
yeah,
keep them on, continue the
yeah,
sildenafil.
as
As a
a
monotherapy,
treatment
yeah.
of symptoms as opposed to the underlying disease at that point.
In regards to initiating it
Yeah.
new for a terminal end of life situation, I don't really see a lot of data. In my experience, sildenafil as a solo agent doesn't really provide
Okay.
a lot of symptomatic benefit.
Mhm.
Hemodynamic benefit, maybe at 6 months to a year on a follow-up echo, you might see some reduction. But solo agent, I don't know. The good news is all the ERAs are now moving to generic, so hopefully we'll have some improvement in the cost to patients.
Great.
A comment and then a question. A comment, another, kind of following that from Dr. Earnshaw, she says, to me, it seems that ambulatory ability and exertional stamina are the main outcomes of these medications.
Mhm.
So if they are bedbound, it seems clear they are not very helpful.
Yeah.
And then a question from Dr. Sirachbi, from rheumatology, says, can you comment on pregnancy and pulmonary hypertension? What to do if your patients become pregnant in spite of advice not to do so? And also comment which medications are safe to use in pregnancy.
Okay, so pregnancy is a challenging situation. I haven't really had to deal with a pregnant pulmonary hypertension patient here at UofL. The one patient we had was severe enough where we had to contact, OBGYN and get her in for like an emergency abortion, and which was what she wanted. So it worked out in that situation. But the guidelines say we have to stop endothelin receptor antagonists all of the time, all of them. And with pregnancy, it's a wildly variable situation because the blood volume and the hemodynamics change with each trimester. And so the recommendation is to put them on a parenteral prostacyclin agent. And we have to have them admitted for, right heart cath every probably 6 weeks to 3 months and have a titration done to the parenteral prostacyclin. I know there is Temple in Philadelphia. Temple University is working on allowing pregnancy and pulmonary hypertension and kind of working in that little gray area. I know most centers will recommend against pregnancy. But yeah.
And two more questions. One is actually from Dr. Krishnasamy. So, is there any improvement with GLP-1 or I guess GLP-2? SGLT2?
SGLT2, yes.
Okay.
So that has been my big question too, because obviously, we've seen SGLT2 inhibitors improve the heart failure. They've kind of been a game changer in the heart failure world. There is a study in Belgium and another one in Denmark looking at SGLT2 inhibitors specifically for pulmonary arterial hypertension. They haven't been published yet, so I don't know what the prelim data is. We were thinking about doing a pilot trial through our clinic where we started, maybe 10 or 15 patients on it and seeing how they did. However, it is challenging to get monetary support for the medications, especially if the patients don't have a diabetes or an indication that their insurance is going to approve an SGLT2 for. So I reached out to the pharmaceutical companies to see if they would be willing to provide us a supply for this trial. Unfortunately, a lot of them are no longer supporting it because they already have their indications and yeah. So Dr. Krishnasamy, that's going to be a TBD. I will keep you guys updated on if we find more.
Thank you.
Hey, thanks, Dr. Krish. Dr. Armstrong in rheumatology says, one additional rheumatology question. Do you think there is a role for immunosuppressant therapy in CTD-associated PAH?
I think there is. I think controlling their connective tissue disease is like with everything PH, treating the underlying cause is going to be beneficial. I just don't know if, say, for example, a scleroderma patient, if we get them to the point where they already have irreversible changes, I don't know how much more immunosuppression is going to help at that point. However, if we can capture them earlier, I feel like that would be beneficial.
One last question. Says, do patients with COPD something, this is, I think this is typo. So do patients with COPD and is COR pulmonary benefit from pH directed therapy? If so, when should it be started and what is the initial therapy?
Yeah, so COPD in general, I was always taught all through fellowship was that if it's group 2 or group 3 pulmonary hypertension, you treat the underlying cause. You don't do pH directed therapy. Part of the challenge with COPD patients is if you put them on pulmonary vasodilators, you're going to reverse their VQ matching that was already happening. And you're going to increase perfusion to poorly ventilated areas and possibly worsen hypoxia. That was the theory behind it. Now there are some trials showing some improvement in, symptoms and mode classification and stuff like that for COPD patients. So I would say it's a case by case. It's hard to give a blanket recommendation for COPD cor pulmonale saying all of them need treatment. I think it's something that we can try and we do this all the time in my clinic where we're like, this is not evidence-based, we're gonna try it. We're gonna have a close follow-up or phone call or televisit in a month and see if you're feeling better. If you're not, then we back up or we change directions.
And that's all.
Well, that's really remarkable and great engagement, and it obviously is an area where people have a lot of questions, and we need to know more and how it applies to so many different diseases. So thank you so much for that wonderful overview.